Good afternoon, everyone, and thank you for the presentation and also for the invitation. And thank you all for attending this online seminar. It's well known inflammation is an adaptive response that is triggered by noxious stimuli and conditions such as infection and tissue injury. It consists of sequential and complex changes and ultimately aims at eliminating or isolating the damaging agent, as well as repairing or replacing damaged tissue. Inflammation is therefore a defense mechanism that is vital for health. Functionally, two types of immune response are responsible for inflammation in superior organisms, the innate and the adaptive systems, and both work in an integrated manner. The innate immune system is the first line of defense against infection or injury and has been classically associated with acute inflammation, such as that mediated by urate macrocrystal in a good flare. As you know, the deposition of urate crystals, such as those ones, in the joints initiates a rapid and self-limiting inflammatory response that usually resolves within a few days, in a process in which only the innate immune response is involved. In the damaged tissue, the synovial membrane, a massive infiltration of neutrophils and macrophages is observed from the first hours of the flare-up. You can see here the staining of macrophages remaining in the tissue 72 hours after the insult. This slide summarizes the main characteristics of the innate immune response. It's a system always active in healthy individuals and ready to block noxious agents that do succeed in entering host tissues. The response is triggered by pathogens or by the presence of mediator release following cell and tissue injury. There are no specific receptors to activate the response, but pattern recognition receptors that just recognize patterns of molecules. The ligands of these receptors are called PAMPs for pathogen-associated molecular patterns, and include double-stranded RNA, lipids, or carbohydrate complexes. And in contrast, the molecules derived from damaged cells, the so-called DAMPs, for damage-associated molecular patterns, which induce the so-called sterile inflammation, include microcrystal head shock proteins, or ATP. This response, clinically, is called acute inflammatory response, is resolved in 2 to 14 days. The immune cells involved are detailed here, and they are mainly macrophages and granulocytes, especially neutrophils. So there's no specificity in these receptors in the response inducers. There are a limited number of different receptors which are encoded by inherited genes, and there is no or a limited memory in their response. The properties of these receptors are described here. They are mainly toll-like receptors, or TLR. Up to 9 different TLR exist, most of them located on the plasma membrane, while others are located intracellularly. And also the node-like receptors, which are always found in the cell cytoplasm. This is the typical time course of an acute inflammatory response. As a result of a signal of damage that is sensed by the resident cells, usually macrophages, different inflammatory mediators are released, inducing vasodilation and vascular leakage, which is responsible for edema observed in a very short time. This process allows the recruitment of inflammatory cells to the sites of damage, mainly neutrophils and macrophages, or monocytes, that differentiates into pro-inflammatory macrophages in the presence of cytokines and also inflammatory lipids. Neutrophils are in charge of phagocytosis and elimination of the noxious agents, and so are macrophages. The progressive decrease of the neutrophil content and the increase in the macrophage content are key events of this process. In fact, neutrophils die liberating their DNA, which form the so-called nets, able to trap pathogens, microcrystals, cytokines, etc. Events of apoptosis and tissue remodeling are observed. And after the induction of the inflammatory response, the pro-resolving response that will eventually lead to tissue homeostasis is also initiated. Resolution of the inflammatory process is not a passive event in which the response simply weakens or discontinues, but an active process that shuts down the inflammatory response and allows the regeneration ad integrum of the damaged tissue. The elimination of the noxious agent is the first determinant for resolution that stops the production of pro-inflammatory mediators and induces a class switching in the lipids release to become specific lipids or specific pro-resolving mediators. This causes a decrease in cell recruitment. These pro-inflammatory mediators are associated with the repolarization of tissue macrophages. As you know, the macrophage is an absolutely plastic cell, which under this condition repolarize to an anti-inflammatory cell responsible for the non-phlogistic removal of apoptotic neutrophils and the tissue debris, which allows the repair of the damaged tissue. However, if the aggression is not adequately resolved or it is continuous over time, the long-term consequences of prolonged inflammation are not so beneficial. We used to define the situation related to loss of function and loss of structural integrity as chronic inflammation. In the skin, for example, a permanent aggression would acquire the appearance of the slide with an extensive angiogenesis and hyperplastic appearance. Plausibly, this is the case with cartilage damage in osteoarthritis, where there's no vascular substrate. The continuous mechanical aggression damages the cartilage and generates a chronic injury. The avascular destruction of the cartilage results in the release of matrix fragments and cellular debris, which are a source of inflammation for itself and the rest of the joint tissue. This inflammation is primarily the result of chronic local activation of innate immunity. In fact, a usual form for OA progression is that occurring in flares. These flares could perfectly fit with episodes of tissue destruction or microcrystal presence that's very common in osteoarthritic patients. These events would perpetuate the activation of the innate immune response. What type of agents stimulate innate immunity in the joint cells? Well, it has been demonstrated that TLR2 and 4 can be stimulated by mechanical stress in chondrocytes. As mentioned previously, cartilage proteins and damaged cell debris are able of stimulating these receptors too. Additionally, metabolic alterations such as increase in free fatty acids, cholesterol, glucose, or microcrystal stimulate innate immune response both in chondrocytes and synovial cells. As a whole, the long-term presence of these noxious agents is translated intracellularly as endoplasmic cell reticulum stress, mitochondrial oxidative stress, and dysregulation of autophagy, which overactivates the stress response in the cell. In this context, important nuclear factors are activated, such as nuclear factor kappa B or AP1, responsible for the gene expression of pro-inflammatory enzymes, metalloproteinases, or cytokines that are the final effectors for cartilage destruction. Thus, joint cells are chronically inflamed in osteoarthritis. Indeed, the activation of the innate immune system can be observed in vivo. You can see here how the presence of TLR4 is increased in the cartilage of osteoarthritic patients, specifically in damaged regions. Besides, activation of TLR4 is also evident in the synovial membrane, together with other markers of cell activation. Regarding the activation of pro-inflammatory nuclear factors, we described years ago that human osteoarthritic chondrocytes show an increased presence of NF-kappa B in the nuclei when they are stimulated with inflammatory cytokines and other mediators that are locally increased in the OA joints. The inhibitory subunit I-kappa B is degraded upon the activation of this factor, and the heterodimer migrates to the nuclei, where activates the gene expression of pro-inflammatory cytokines, enzymes, and proteases. In the presence of pathogens, an adaptive immune response is just activated after the innate response, days after the exposure to the noxious agent. Among the differences between the two types of response, the adaptive one generates immunological memory that lasts years, not days. And in addition, the main cells involved are B and T lymphocytes. Furthermore, specific antibodies neutralizing the aggressor are synthesized in order to block these agents. Briefly, this would be the time course of an adaptive response that resolves over time. The initiation cells of this response are just those mentioned in the innate response, macrophages and dendritic cells, which present the pathogen proteins recognized as antigens to the quiescent lymphocytes. T lymphocytes are the main controllers of adaptive immune responses. Once activated, these cells expand, proliferate, and differentiate into different subtypes and act on the rest of the cells present, directing the macrophage and the B cells' responses. As described early, inflammation is resolved by the clearance of cellular debris and the aggressor agent by phagocytes. However, the adaptive immune response becomes chronic sometimes when autoimmune phenomena occur due to different reasons. A typical example is rheumatoid arthritis, the paradigm of chronic systemic inflammatory joint diseases. It's really a complex disease in which the main character cells, as I mentioned, are T and B lymphocytes, which, as you can see here, commonly are found in the synovial membrane, here forming lymphoid aggregates. This target tissue is highly inflamed and actively degrades other joint tissues. This is a section of a rheumatoid arthritic joint showing the localization where the synovium, the cartilage, and the bone meet. You can see here how the synovial membrane penetrates into the cartilage, the articular cartilage, degrading it, and also into the calcified cartilage, where you can see how an osteoclast is literally eating the tissue, and also the synovium transformed into an invasive tissue is here eroding the bone. Besides the inflammatory joint injury associated with the perpetuation of the autoimmune response, rheumatoid arthritis is characterized by marked inflammation in extra-articular localization. However, this extra-articular inflammation is more associated with the activation of the innate immune response in the different tissues. As you know, systemic osteoporosis, the exacerbation of atherosclerosis and other thrombotic events, or muscle wasting are frequent in these patients. In fact, this mixed pattern of autoimmune disease with some characteristics of autoinflammatory disease too is not exclusive to rheumatoid arthritis. Rather, the spectrum of human chronic diseases can be places in this cartoon, which nicely reflects how inflammation associated with the activation of both systems is present to a greater or less extent in most chronic human pathologies. In addition to the acute and the chronic inflammation that we learned about years ago at university, there's another type of inflammation commonly related to metabolic alterations. It's a different type of response, not related to the classical signs of inflammation, less intense, difficult to be detected, and thus diagnosed and treated. If you parallel the inflammation to the fire, it would be closer to the embers of the fire than to the flames of an active fire, but it's more difficult to be extinguished. Low-grade chronic inflammation is mainly caused by an excess of nutrients and is associated with the interaction between the immune system and the tissue response during overnutrition and obesity. Of course, it shares common mediators to those described in classic inflammation, and these mediators have an impact both locally, for example, in the joint, and systemically. We know years ago that obesity and overweight are risk factors for osteoarthritis. However, it's clear now that there is both a mechanical contribution to joint damage, but also a systemic inflammation induced by obesity that is aggravating osteoarthritis. This is one of the studies designed to examine the relationship between metabolic alteration and osteoarthritis. Authors studied the association of metabolic syndrome and its components with the prevalence or the incidence of osteoarthritis. As you can see here, author demonstrated that metabolic syndrome, but also the number of its components, are associated with incident osteoarthritis, as you can see here, by a higher relative risk of osteoarthritis. These associations were not independent of body mass index or body weight, since they almost disappear when adjusting for this parameter. When interpreting these studies, it's essential to bear in mind that adjusting for BMI means adjusting for the full effect that obesity entails, and not just correcting for the mechanical effect. If the contribution of obesity to osteoarthritis seems clear, despite the large mechanical component in the knee as a weight-bearing joint, it's even more evident in studies in non-weight-bearing joints as the hand. These are the results of a meta-analysis of the association between BMI and hand OA development. Based on different high-quality studies, a positive association can be observed. Furthermore, latest studies of this group show that the serum concentration of soluble factors related to obesity, such as adipokines, mainly released by the adipose tissue, could be the basis of this association. As you can see here, patients of the two highest tertiles of adiponectin concentration, whose synthesis is inhibited in the fat tissue of obese patients, had a 70% reduced risk of hand osteoarthritis progression in comparison with patients in the lowest tertile. Therefore, these and other clinical studies have evidence that the contribution of obesity and metabolic dysfunction to osteoarthritis goes beyond the purely mechanical effect. The systemic impact of this low-grade chronic inflammation that is present in obese patients can be measured. In this report, the authors showed that the serum levels of different adipokines and inflammatory markers are elevated in the serum of obese patients, although they are clearly far from those observed in patients with, for example, rheumatoid arthritis. The systemic inflammation is clearly different. CRP values around 1 or IL-6 around 5 are probably not so elevated to be considered, and therefore this alteration is difficult to diagnose. However, as you can see, these values significantly decrease only 6 months after massive weight loss. So the basis of the real impact of this systemic inflammation is the chronicity of itself in a long-term disease such as osteoarthritis. Therefore, obesity and overnutrition induce metabolic stress in different cells and tissue, which is responsible for the systemic increase of inflammatory mediators and adipokines. This condition induces a state of low-grade chronic systemic inflammation, which in turn aggravates the course of many different diseases. In fact, low-grade chronic systemic inflammation is the main driver of many chronic diseases such as osteoarthritis. The main origin of pro-inflammatory mediators in this condition is the adipose tissue, as addressed by different studies. Overnutrition induces the synthesis of cytokines such as TNF, IL-6, IL-1, IL-17, or adipokines, and inhibits the presence of anti-inflammatory mediators such as IL-10 or adiponectin. Different phenomena such as hypoxia due to cell overgrowth or the polarization of macrophages towards a pro-inflammatory phenotype are characteristics of this obese tissue that becomes an insulin-resistant organ. With this pathophysiological description of osteoarthritis regarding the role of both local and systemic activation of the innate immune response triggered by mechanical stress, different ligands of the TLR, and the contribution of obesity, what should be the targets for emerging therapies for this disease? We consider that these targets should be different mediators responsible for the transmission of the inflammatory response at multiple levels, both inside and outside the cells. Probably the use of different agents able to act synergistically on the master regulators of inflammation would be a promising approach. In line with this proposal, the oral combination of several molecules, on the one hand proteinases with the ability to regulate the local and systemic inflammatory activity, such as bromelain and trypsin, together with the administration of an agent with antioxidant and anti-inflammatory properties, could block the inflammatory response at several levels, as we will see in a minute. The presence of proteinases regulates the protein alpha-2 macroglobulin, a very ubiquitous protein in highly concentrated in serum. This mediator is activated by proteases, which integrate into its structure. In this way, alpha-2 macroglobulin behaves such a natural inhibitor of metalloproteinases, as there are many others in the organism. In addition, alpha-2 macroglobulin is able to regulate the inflammatory and the pro-resolving response because it acts by trapping both pro- and anti-inflammatory cytokines, facilitating the process of resolution. Besides, the different bioactive phytochemicals, such as those one mentioned here, have been described as important anti-inflammatory and antioxidative mediators. Among them, quercetin, or 6-sogaol or 6-gingerol extracted from ginger, curcumin, resveratrol, etc. These compounds are able to target different mediators in the TLR4 signaling pathway at different levels. In our group, we have recently described that 6-sogaol is able to interrupt the signaling by direct binding of this molecule with the TLR4 receptor complex. And independently of this property, 6-sogaol was able to inhibit different kinases in the intracellular pathway and has an antioxidative effect, modulating mitochondrial signaling. In line with these properties, we have demonstrated that this molecule, 6-sogaol, orally administered, is able to ameliorate cartilage damage in an experimental model of osteoarthritis in mice. As you can see here, mice underwent knee surgery to destabilize the joint and received daily this drug. The analysis of the cartilage pathology 8 weeks after the surgery showed that these mice treated with 6-Yogagol show a significant diminution in the cartilage lesions observed both in the tibia and in the femur when compared to the untreated mice. Interestingly, recent data also suggests that these compounds could have a systemic effect through the modulation of fat tissue dysfunction associated with obesity. Quercetin administration decreased systemic inflammation and improved insulin resistance in rats fed with a high-fat diet, an effect that is mediated by the blockade of innate immune signaling. In line with all this data, a meta-analysis from different prospective trials comparing oral enzyme therapy with bromelain, trypsin, and rituximab versus diclofenac conclude that the combination of this drug was a safe treatment with comparable efficacy to that observed for diclofenac. In summary, osteoarthritis can be described as a chronic wound in the cartilage characterized by a permanent activation of the innate immune response in the joint cells, either the mechanical alteration itself, cartilage degradation products, apoptotic cell debris, or an excess of nutrients trigger this chronic joint response. In addition, obesity worsens the development of osteoarthritis both in its mechanical contribution and by triggering chronic low-grade systemic inflammation. In obese individuals, fat tissue is mainly responsible for this chronic inflammatory activation. Innovative therapeutic strategies and the treatment of OA should take into account the systemic treatment of this disease, contemplating synergistic therapies acting by the modulation of different factors mentioned. In this sense, oral enzyme combination could regulate the activity of pro- and anti-inflammatory cytokines, but also the catabolic enzymes that degrade the cartilage. The flavonoid quercetin, as has been described for other flavonoids, has potent antioxidant and anti-inflammatory properties, blocking the innate immune response. Furthermore, quercetin has been shown to reduce systemic inflammation induced by the activation of fat tissue in experimental models of obesity. Therefore, it's worth it to design appropriate clinical studies that will allow us testing the efficacy of this type of drugs in the treatment of human osteoarthritis and probably other pathologies in which chronic systemic inflammation mediated by a persistent and recurrent activation of the innate immune system plays a relevant role. Thank you very much for your attention, and thank you to the other members of my lab.